It's the end of the day, and all you guys need is an hour and a half of surgical talk, right? So what I'm going to try to do is I'm going to try to do it as painless as possible. Instead of actually just talking about surgical technique after surgical technique, etc., I'm going to focus on, I have nothing to disclose. I'm going to focus on a few of the lesions that I think would be more important to talk about. And I have embedded a few questions throughout the presentation to make it a little bit more dynamic. And the things that I'm going to focus on is a little bit of anatomy, what are the indications for surgery, some of the surgical techniques, and most importantly, what are the expectations after some of these surgical interventions. So we'll start with ventricular septal defects. So as you guys know, there's different classifications of VSDs. And in general, a large VSD is defined as a VSD that's unrestricted to flow and pressure. So basically, there's going to be equilibration of pressure between the LV and the RV. And that means that, for the most part, the size of the VSD is going to be equal to the diameter of the aortic annulus. And this is just one of the suggested classifications. But most importantly, we're going to be talking about the different classifications of VSDs by location. So as you guys know, the most common VSD is going to be your perimembranous VSD. And the definition of a perimembranous VSD is actually a VSD that's going to be in continuity with the tricuspid valve and the aortic valve, and there's going to be continuity between the aortic valve and the tricuspid valve. That means that if there's a little bit of rim of tissue between the tricuspid valve and the defect, it is not a perimembranous VSD. Now, why is this important? It's important for us because the conduction system is going to be different if there's a small rim and it's a muscular VSD rather than a perimembranous VSD. Now, another type of VSD is going to be your inlet VSD, and a classic inlet VSD or AV canal type VSD, you're going to have your mitral and your tricuspid valve at the same levels, and you're going to have the border of one of the borders of the VSDs be the actual tricuspid valve. Now, this is also different from a muscular inlet VSD, in which there's going to be a rim of tissue, again, between the AV valve and the defect, and also the conduction system is going to be differently located on a muscular inlet VSD than on an inlet VSD. The doubly committed juxtaarterial VSD or supracrystal VSD or subpulmonary VSD or however you want to call it, it's a VSD that's related to both the pulmonary valve and the aortic valve. And the way you distinguish these VSDs is that there's actually no infundibular septum or a very short infundibular septum between the aortic valve and the pulmonary valve. So normally the pulmonary valve kind of sits up on a little piece of muscle, the conus or the infundibular septum. In these patients, the pulmonary valve is going to be displaced inferiorly, and there's going to be continuity between the aortic valve and the pulmonary valve. And we'll talk a little bit more about these particular defects in a second. And then anything else that's on the muscular septum that has a muscular rim throughout, completed muscular rim is going to be a muscular VSD, and that can be apical, mid-muscular, high muscular, posterior muscular, however, depending on where exactly it is located. So as you guys know, most VSDs will close spontaneously. So approximately 80% or more of the VSDs that you have as a newborn are going to close on their own. Now the rate of closure of VSDs decreases with age. So if you actually have a 3-year-old that has a VSD that hasn't closed, then the likelihood of that VSD closing is about 10%. And that continues to decrease with time. And this is important as you guys are seeing patients with VSDs to actually say, okay, well, this VSD on an 8-year-old, well, what is the likelihood that that VSD is going to close in the long term? And is this a VSD that actually needs intervention? So there's a question here. So which type of ventricular septal defect is most frequently associated with aortic valve prolapse and aortic insufficiency? So it's a supracrystal, subpulmonary, or doubly committed juxtaarterial VSD, mid-muscular, high muscular, inlet, or apical. So correct. So it's going to be a supracrystal VSD. That's the right answer. So you can have several VSDs that can be associated to aortic valve prolapse and aortic insufficiency. Other VSDs that can have this are perimembranous VSDs, although the likelihood of a perimembranous VSD having aortic valve prolapse is lower than a supracrystal VSD. And sometimes high muscular VSDs that are very close to the aortic valve can also have aortic valve prolapse. Now, when we talk about aortic insufficiency, why does it happen? So this is a doubly committed VSD. As you can see, the aortic valve and the pulmonary valve are at the same level. There's no infundibular septum. And something to note here is that when you actually look at an echo of a supracrystal VSD and you see a very small quote-unquote defect, you're actually just seeing the shunting here. But the VSD is really all this area. So a lot of the VSD is actually covered by one of the cups of the aortic valve. So what happens with this is you obviously have left to right shunting from the LV to the RV. That causes a Venturi effect that then pulls the aortic valve into the, a little bit into the RV, and that creates your aortic insufficiency. And classically, this aortic insufficiency tends to progress with time. And that's the reason why it's important to recognize when you actually have the onset of aortic insufficiency on a patient with a doubly committed VSD, that's probably a patient that should get a repair. Now, this is an older study of the natural history of doubly committed juxtaarterial VSDs, and this is the incidence of developing moderate to severe AI. So as you can see, almost universally, every patient with a doubly committed VSD will develop moderate to severe AI by their teenage years. So this is also the rationale for recommending intervention early in life for these defects. So what are the indications for closure of a VSD in general? So a large defect that's not going to close, there's no reason to watch it for longer than infancy. Obviously, heart failure symptoms or failure of medical management. As we talked about, doubly committed juxtaarterial VSDs or inlet VSDs, they won't close. If you have aortic valve prolapse or insufficiency to prevent progression of disease. Left heart dilation is a little controversial, but what left heart dilation will tell you is that the degree of left to right shunting is significant, so it's usually a corollary of a big defect. And obviously other things like recurrent respiratory infections, failure to close later in life. Now this is also a little controversial. When do you pull the trigger and close a VSD that hasn't closed? There's no answer, and if you ask different people, they'll give you different answers. But at some point, a defect that hasn't closed is probably not going to close, as we saw on that graph. And obviously, if you have endocarditis, which is what you're trying to prevent by closing defects that have persisted. The most common way of closing a defect surgically is a transatrial approach. So we open the right atrium and working through the tricuspid valve. In this case, you have a perimembranous defect with basically the border being the tricuspid valve, and you see the aortic tricuspid valve continuity. And you can close it either with pledges or running, etc. In the case of doubly committed VSDs, those are actually very hard to see through the atrium and very hard to differentiate between the pulmonary valve and the aortic valve that are totally decompressed when you're actually looking inside of the heart. So these defects are better addressed through the pulmonary valve. So we make a small pulmonary arteriotomy, and working through the valve itself, we put some of the stitches, as you can see, on the pulmonary valve annulus, because there's really no infundibulous septum to secure that patch on the upper rim, and then we complete the rim. Now, something important here, as we talked about, is that conduction system is not going to be anywhere near unless these defects actually extend into the perimembranous area. So the lower rim is actually a completely muscular rim. In some situations, we can actually do a transventricular approach. This is very uncommon, but for example, this is a case of a very apical large defect, and you can actually just do a transventricular approach and then close the defect directly. So another question. So the surgical repair of which of the following VSDs is associated with a higher incidence of injury to the conduction system? Correct. So the inlet or AV canal type defects will be the most, with the perimembranous defects will be the most possibly affected. Why is that? Well, this is the anatomy of a perimembranous defect. So as you can see, the AV node here lives in what we call the triangle of Koch, which is the tricuspid valve, a little fold that's called the tendon of Todaro, and the coronary sinus. This AV node then gives a bundle of His, which will cross the tricuspid valve annulus and usually just descends here and divides into both bundles. Obviously, since there's a defect there, that means that the bundle of His gets deviated to the posterior inferior rim of the defect, and it actually runs just on that rim. So that's where it's at risk. The same thing happens with an AV canal defect. The defect's actually going to be large, and it's going to be exactly where the AV node would be going. So the AV node, not only the bundle, but the AV node, they both get displaced posterior inferiorly. So this is the IVC area, this is the SVC area. So they actually go displaced inferiorly, and they're actually running on the crest of the septum on the posterior inferior area. When we have for example here, a doubly committed defect, the AV conduction system is going to be normal, and as I mentioned, there's a rim of muscle that's actually going to separate that conduction system from the defect itself. What are the potential complications? Well, right bundle branch block is not that unusual just because where you're putting the stitches is actually where the bundle is. So about 20 to 45% of perimembranous VSDs will have some right bundle branch block after surgery. That being said, permanent complete heart block should be an almost never occurrence. Other arrhythmias, JET, SVT, VT are possible, and the mortality should be obviously less than 1%. So what do you expect? Extremely low mortality, sinus rhythm or extremely low risk of heart block, low morbidity, a short hospital stay, usually less than 5 to 7 days. Normal LV size and function. And I do want to mention here that if you have a very large VSD, it's not uncommon on the TEE immediately postoperative to see, just because of the change in the loading conditions of the heart, to see some quote-unquote dysfunction. That should get better with time, usually in a few days. And excellent quality of life and surgical cure. So let's switch gears to AV canals, or atrioventricular septal defects. So as you guys know, a complete AV canal, you're going to have, it's an endocardial cushion defect, and you'll have a very large primum ASD, a very large inlet VSD, and a common atrioventricular valve, instead of having a separate mitral and tricuspid valves. Now, when we talk about quote-unquote partial canals, that's on the other side of the spectrum, and you'll have no VSD. You do have a primum ASD, and for the most part, you're going to have two separate atrioventricular valves. We talk about some in-between stage that's called a transitional canal, and that usually means that you have somewhere in between. So you may have a common AV valve with a restrictive VSD, or a VSD that actually just closed with aneurysmal valve tissue, and you have minimal shunting, and you have a primum ASD. The Rastelli classification is basically commonly used to classify these defects. That's based on the superior bridging leaflet anatomy. So if you actually look at the common AV valve, this is inferior, this is superior, this is right, and this is left. A Rastelli A is going to be a valve that's going to be divided in the superior bridging leaflet with attachments to the crest. A Rastelli C is going to be one that the superior bridging leaflet doesn't have any attachments to the crest. Now, as a definition, tetralogy canals, TET canals and DURV canals are Rastelli Cs. Why is that? Well, because here where you see the crest or the septum, that's where the aortic valve is going to be, because it's actually overriding. So you can't really have attachments because they would be going to the aortic valve. So they're all, for the most part, I would say, Rastelli Cs. Rastelli Bs are very uncommon. They usually happen on unbalanced canals, and that's when you have a straddling cord, straddling attachments, depending on the type of balance that you have. So the presence of the defect is going to be an indication of surgery at some point. Now the timing is it's also a little controversial, but for the most part, if you have a complete AV canal, there's no reason to wait beyond 4 to 6 months, and you're actually just going to be creating more ventricular overload, ventricular distension, and probably worsening AV valve regurgitation. So most centers would recommend elective timing between 4 and 6 months, unless there's an indication to do it earlier. Asymptomatic patients with partial transitional canals, usually you can push them. It's essentially an ASD. So provided there's no significant AV valve regurgitation or any other indication, you can do it at 3 to 4 years of age. So what's going to prompt early intervention? Well, heart failure symptoms, resistant to medical management, significant AV valve regurgitation. And if you have older patients that may have high pulmonary vascular resistance, then a cardiac catheterization may be warranted. What are the surgical techniques? There's 3 techniques in general that we use: a 1-patch, a 2-patch, and what we call the Australian technique, or the modified 1-patch technique. The 1-patch repair involves just literally 1 patch, the same patch used for both the VSD and the ASD closure. But in order to do that, that means that you have to divide the atrioventricular valve in order to fit that patch in there. So the upside of that is that you can actually have very good visualization. The downside, potential downside, is that you're dividing the valve and then resuturing to the patch, so you may be losing a little bit of valve tissue there. The 2-patch repair uses separate patches, one for the VSD, one for the ASD. You don't need to divide the valve. The downside of this is that it's actually a little bit more difficult to visualize because you're putting that VSD patch under the valve and you're having to pull on the valve. But it's probably, you're not losing that valve tissue just from suturing the valve to the patch. And then the Australian technique just uses one patch, but what it does is you put stitches on the ventricular septum, and those stitches are passed through the valve, and then you put the patch. So what you're doing is you're pulling the valve down into the VSD. Now, the advantages of this is that it's probably the easiest of the three techniques and is the more reproducible. Some potential downsides are potential distortion of the valve, especially if your VSD is very deep. And in some series, there's an increased rate of left ventricular outflow tract obstruction just because of that pulling down of the AV valves into the left ventricular outflow tract. The conduction system, we talked a little bit about it. So if you're actually looking, this is the right side, this is the left side. This is the coronary sinus. It's going to be here, very close to the crux of the heart. And that AV node is going to give your bundle. The bundle is going to travel on the crest of the septum, and it's going to, the left bundle and the bundle of his is actually going to go mainly on the left side. So that's the reason why we try to put the stitches mainly on the right side as we're actually creating our patch. Now, when the patch comes up here, there's two ways of dealing with the AV node so you don't injure it. One is to go around the AV node with your patch, but that means that the coronary sinus is going to stay on your left side. Now, the amount of shunting that you get from leaving a coronary sinus draining into the left atrium is not that big, so it really shouldn't even change your saturations. The other option is to go here on the left AV valve a little bit until you reach the coronary sinus and then come out. The advantage of that is that you're leaving the coronary sinus on the correct side, on the right side, but you are going to need to cross the area where the bundle of his potentially is crossing through. What are potential complications? Arrhythmias, just like a lot of these. Right bundle branch blocks are not unusual. First degree block is also not that uncommon in these patients, 30 to 50%, just because of the conduction system being so close. That being said, complete heart block should also be pretty low. Perioperative mortality is going to depend on the profile of patients. Some patients, as you know, are very sick going in. Obviously, those patients are going to have a higher risk of morbidity and mortality. And then the Achilles heel of AV canals, left AV valve regurgitation. So about 10 to 15% of patients will have significant left AV valve regurgitation. If you have significant AV valve regurgitation coming in, obviously that the incidence of AV valve regurgitation coming out is going to be higher. The rate of preoperative reoperation in the series is about 3 to 5%. What are some of the risk factors for complications? So young age and weight and prematurity. So when we're actually have a newborn with an AV canal, the reason why we don't like operating on newborns with AV canals is because the tissues, the AV valve tissues, are just very, very frail, especially for those first month to 2 months. So for the most part, most people won't do interventions unless we really need to. After 2 months of age, whether it's 2 months, 4 months, 6 months, then that's more of a matter of debate. But in general, we try to avoid newborn canals for that reason. As I mentioned, if you have a normal AV valve or preoperative AV valve regurgitation, that's going to be important. Interestingly, this is one of the few diseases where syndromes are actually a good thing. So if you have Down syndrome, the likelihood of you having a better result is higher than if you don't have Down syndrome. And the reason for that is that the left AV valve on patients with non-Downs canals tends to be a little smaller. The mural leaflet is underdeveloped. So we really struggle with the left AV valve on patients that don't have Down syndrome for some reason. So Down syndrome is actually a protective factor on patients with canals. Unbalanced anatomy, associated cardiac anomalies, and comorbidities. Those are obvious. So another question. So the most common reason for long-term reoperation after repair of AV canals is left AV valve regurgitation, LVOT obstruction, residual VSDs, right AV valve regurgitation, or AV block requiring insertion of pacemaker. Correct. So left AV valve regurgitation is going to be your main reason for long-term reintervention in these patients. And LVOT is also an important consideration, but it's not as common. So the incidence of left AV valve reoperation is somewhere between 10 and 15% compared to 2 to 5% on LVOT obstruction. And survival is usually 85 to 90% at 10 years, particularly because of comorbidities. Now, why does LVOT obstruction happen? Well, on a normal heart, if you see here, the aortic valve, the mitral valve, and the tricuspid valve are basically together on the cytoskeleton of the heart. And the aortic valve is going to be nested within these two valves. When you have a canal and you have a common atrioventricular valve, by definition, that aortic valve is going to be pushed out of the way a little bit. And that increases the dimension of the outlet and causes that gooseneck deformity that we call on your left ventricular outflow tract, potentially causing left ventricular outflow tract obstruction. Another cause of left ventricular outflow tract obstruction is going to be just AV valve chordal tissue, accessory chordal tissue that can also obstruct the LVOT. So question, 3-week-old non-syndromic newborn, 2.5 kilos, postnatally diagnosed with a Rastelli B, moderately unbalanced right ventricular dominant AV canal with trivial AV valve regurgitation and an adequate aortic arch. The best next step on the management of this patient is, so a 2-patch repair with a fenestrated ASD, a PA band, management with diuretics until a Glenn, management with diuretics until later septation, or complete septation with an incomplete closure of the cleft. Wow, that's a good question, I guess. So so I think it's placement of PA bands. So usually we don't like placing PA bands on patients with canals. Now, there are a few things about this patient. So you have a moderately unbalanced canal. So that means that this patient, we're not necessarily sure whether this patient is going to be able to be committed to a biventricular repair or a single ventricle repair. So you want to protect the circulation in case a single ventricle repair is going to be the next step. Now, the management of diuretics until getting a Glenn, the problem is that you're not protecting the circulation. So when you actually come back with a Glenn, you're going to have potentially high pulmonary vascular resistance, and that's not going to be a Glenn that you want to take care of. And then the management of diuretics with the plan of complete septation later in infancy, that could be an alternative. The problem is that if you actually need to go on a single ventricle repair once you do an intracardiac exploration, now you're actually talking about a high PVR situation where getting a Glenn there would not be ideal. So for the most part, I think a PA band should be used on very limited circumstances on AV canal and mainly on unbalanced defects that may require single ventricle palliation and maybe on very small infants that require intervention. But for the most part, we don't favor this, especially because of increasing afterload and the likelihood of developing AV valve regurgitation. So let's talk about the tetralogy. So a 6-month-old boy presents with a hypercyanotic spell. He's diagnosed with tetralogy of Fallot with severe subvalvular and valvular pulmonary stenosis. His stabilized and oxygen saturations at rest are 95%. The optimal management strategy for this patient is to start propranolol and elective surgical repair, placing a BT shunt, cardiac catheterization with an RVOT stent, surgical repair during this admission, or initiation of PGE followed by placement of a PDA stent. Yeah, I agree. So obviously propranolol, there's no reason to wait on a 6-month-old tetralogy patient. A BT shunt, especially if your oxygen saturations are 95%, is not gonna be helpful because this is probably a more dynamic obstruction that's causing the problem. And besides, the kid's already 6-month-old. Yeah, surgical repair with during this admission should be the right answer. So I'm not going to go into the details of tetralogy of Fallot, but obviously the cause of the problem is an anterior deviation of the infundibular septum. So a lot of the obstruction in this patient is going to be muscular. So it's going to be dynamic obstruction of the outflow tract, in addition to sometimes, well, most of the time, some degree of valvular obstruction, valvular fixed obstruction. But that's what's actually going to condition your hypercyanotic spells, just compression of that muscle that can create that. What are the indications? Well, the presence of tetralogy is, again, an indication for repair. The timing is a little controversial. So That being said, if you have worsening cyanosis or cyanotic spells, you need to do something about that patient. And the last thing you want is to have a kid with a hypercyanotic spell, send the patient home, and then have the patient have a hypercyanotic spell. That's actually going to cause a major problem. So having a hypercyanotic spell needs an intervention. Now, the timing, whether you repair it very early or delayed, there's so many different schools of thought, and I'm not going to get into any controversial thing here, but those are just two of the options. For the most part, some of the different approaches that have been used for tetralogy of Fallot, the most common one, the most classic one is what we call the classic transventricular approach. In that approach, you basically make a big incision from the pulmonary artery across the pulmonary valve into the ventricle, and then through that ventriculotomy, you close the defect with a patch, and then you put a second patch on the outflow tract and the pulmonary artery. This is very effective to relieve RVOT obstruction. The operation is technically the easiest of all the approaches. The problem is that you're actually doing a big ventriculotomy that is probably going to have consequences in the long term for your patient. Another approach that has been used is the transventricular approach, the isolated transventricular approach, where you do a ventriculotomy to close the VSD and relieve the obstruction. You preserve the pulmonary valve, provided the pulmonary valve is adequate in size. Sometimes some groups have actually used balloons to open that up a little bit more. And then you put a second patch on the MPA if the MPA is small. Now, in this situation, you may preserve the pulmonary valve in some circumstances, but again, you're actually doing a ventriculotomy with the potential consequences in the long term. So the other approach is the transatrial transpulmonary approach. That's the approach that we personally favor. It's a much more challenging approach from a technical standpoint because we do most of the operation through the atrium. So we do a right atriotomy, working through the tricuspid valve. We excise all the muscle that's on the outflow tract, close the VSD, and then we go through the pulmonary artery, make a little opening, do a little bit more of that muscular resection, and then assess the valve and see if the valve actually needs to be, if you need to do something with the valve, like a pulmonary valvotomy or not. If you can preserve the valve, that's great, which usually is possible about 20 to 30% of the time. And if not, you actually just do a mini transannular patch, meaning you extend it just through the annulus and as little as needed to actually allow an adequate size on the outflow, but you try not to go too deep on the ventricle. So there's a lot of controversy as to which one is actually a better strategy, and we don't know, but obviously each center is going to have their own preference on this. In terms of postoperative management, one of the things that you have to keep in mind is that the RV is going to be a pretty hypertrophied RV. So it's going to be very dependent on preload. So sometimes you're actually going to need a good fluid filling of the RV and good heart rate control. If you have a patient that's very tachycardic, it's going to have inadequate filling, inadequate preload, and you're actually going to compromise your cardiac output. And some of these circumstances, you have to know that there may be some residual RVOT obstruction. If we preserve the pulmonary valve, there's probably going to be some degree of RVOT obstruction if the valve's a little small. Or if we actually do a transatrial transpulmonary approach with a very minimal transannular patch, there's still going to be muscle there that can cause some dynamic outflow tract obstruction with the hopes that that'll get better with time. But to control residual RVOT obstruction, you're also going to want low heart rate and good fluid management. What are some potential complications? Arrhythmias, JET. The incidence of JET varies a lot between centers. It goes somewhere between 5% and 30%, depending on the series that you read. Complete heart block should be also pretty low, and perioperative mortality nowadays is also very low. This is a study now from 2010, just to give you guys an idea of the difference in patterns of usage from the Society of Thoracic Surgeons database. And as you can see, the vast majority of centers are operating on patients somewhere around 3 to 6 months, to a certain degree 6 to 12 months, and most centers are not necessarily operating on newborns. The overall mortality is about 1.3% in the entire series. The vast majority of patients are still being done, this as of 2010, through a right ventriculotomy, and also a vast majority were a transannular patch. And then the operative mortality for those series was actually quite high. It was 7% for repair and 6% for palliation. Now, again, this is about 10-year data, and it includes the entire spectrum of all centers in the US, but it's something to keep in mind. In general, the overall survival should be pretty good. Should be about 96 to 97% long term. And the freedom from reoperation should also be pretty low. So it should be somewhere around 3 to 10% at 5 to 10 years, depending on the series that you read. Now, one of the big things about tetralogy is going to be obviously the need for pulmonary valve replacement. So you're going to have at some point, because of the free PI, you'll have pretty significant RV dilation. And as you can see here, you have RV dilation, and you can see that patch of the ventriculotomy that's just non-contractile, and that's not obviously not contributing to cardiac output. This is a patient that had a ventriculotomy. Now, this patient is a patient that was basically had the infundibulum preserved, and you can see how there is contraction of that, muscle contraction of that area of that infundibulum that probably helps in the long term, but we don't have data on that, even though you have free pulmonary insufficiency from a transannular patch. So when should we perform pulmonary valve replacement? Again, a matter of debate. You're going to find as many answers as you're looking for. So RV and diastolic volume probably somewhere about 150 to 170 cc's per meter square. RV and systolic volume probably somewhere between 80 to 85. If you have RV right ventricular dysfunction, you're probably too late for that. And same for ventricular arrhythmias and symptomatology. All right, let's now talk a little bit about transposition. So let's start with a question. So a 4-month-old child presents for evaluation after a murmur was identified by the pediatrician. Oxygen saturations were found to be in the high 80s. An echo reveals TGA with a large VSD. Best treatment strategy: a cardiac cath to assess pulmonary vascular resistance, rapid left ventricular retraining, arterial switch with VSD closure, an atrial switch operation, or a PA band followed by cardiac catheterization in 4 to 6 months. So a 4-month-old shouldn't necessarily have pulmonary vascular changes that would preclude you from doing an arterial switch operation. So a cardiac catheterization, I would say, was probably not necessary on this patient. And in terms of rapid left ventricular retraining, that would be the case if you had a small VSD or an intact ventricular septum. If you have a large VSD, the large VSD is going to actually pressurize your left ventricle, so that left ventricle should still be trained to be able to support the systemic circulation. And then a PA band wouldn't really buy you much time. I mean, at this point, a 4-month-old should be able to get an arterial switch operation, a VSD closure, which that would be the answer. So obviously, when we're talking about a transposition of the great artery, you have two parallel circuits where the blood coming back from the body is going back to the aorta and back to the body, and the blood coming back from the lungs is going back to the lungs. So you're relying on one type of connection in between both circuits. Now, by far, the best connection is actually at the atrial level. So when you have a PDA, the way the PDA actually improves mixing is by increasing the flow into the lungs, increasing your left atrial pressure, and then that left atrial hypertension increases the mixing at the atrial level. So in reality, the best mixing area is the atrial septal defect. So that's the reason why a balloon atrial septostomy would probably be a good idea in most patients with transposition of the great arteries, unless you already have a big ASD. How do we do an arterial switch operation? Well, as you can see, the aorta on the classic transposition will be completely anterior to the PA with some variations. So we stop the heart, we transect the aorta that's in front of the PA, then we take out large areas of the coronaries, with basically a coronary button around each of the coronaries. Then we transect the pulmonary artery that's behind, and we translocate the coronary buttons. Now, there's different techniques on how you translocate coronary buttons, and I'm not going to get into that. But I think in general, what we want to do is really not torque those coronaries. So try to keep the angle as best as we can to avoid coronary torsion. And then the pulmonary root, or the neopulmonary root, is reconstructed with any material. We usually use pericardium for those two sinuses that we cored out the coronaries from. We do a Lecoq maneuver, so meaning the pulmonary arteries are placed in front of the aorta, and then do the connection between the neopulmonary artery and the PA, and that's it. So some of the special considerations that when we're talking about transposition, coronary anomalies, aortic arch hypoplasia, LVOT obstruction, and late presentation. So let's talk a little bit about some of these special considerations. So there's obviously a multitude of coronary patterns. For the most part, most if not all coronary patterns are somehow switchable one way or the other, but some of them actually carry increased risk of a coronary problem afterwards. The usual coronary arrangement is going to be the left coronary coming out of the left-facing sinus, and the right coronary coming out of the right-facing sinus. And then from there, you can have single coronary patterns, you can have juxtacommissural coronaries going around, etc. And as you guys know, now by far the most dangerous and associated with a higher risk of complications in terms of patterns of coronary anomalies, what we call the intramural coronary. And a lot of the times it's actually juxtacommissural. So the aortic valve is going to be inserting here, and you have an intramural coronary that's going behind the post of the aortic valve. So now we're talking about taking down the valve, unroofing this intramural segment, and then translocating the coronary with the translocating that unroofed coronary. So as you can imagine, the likelihood of getting that wrong or causing any minimal compression is higher than in other coronary patterns. Another pattern that's a little challenging, that's very challenging, is a single coronary where each coronary is coming out on different sides. Obviously, this is not something that you can easily translocate, especially if you cannot divide the coronary into two separate buttons. So the most common approach is just to leave the coronary as is, attach it to the inferior rim of the coronary, and then put a patch or put something so we're actually kind of creating a pocket around the coronary. Another pattern, special considerations, obviously when you have aortic coarctation of aortic arch hypoplasia, you can see here a patient with significant aortic arch hypoplasia, and then you're going to need to do an aortic arch reconstruction at the same time as the arterial switch operation. Another consideration is when we have left ventricular outflow tract obstruction. This makes it a very complicated procedure. The options are 4 in general. The first option is to do an arterial switch operation still, and then resect that piece of muscle or whatever is causing the left ventricular outflow tract obstruction. So obviously, this left ventricular outflow tract is now going to be the aortic valve. So that's the reason why it's critical to get this right. And then the other options, which I'll talk briefly about, are the Rastelli, the Rev, and the Nikaido. So this is a patient, just to give you an example. You can see how this is your aortic valve, this is your pulmonary valve, and your left ventricular outflow tract, which looks very small and very narrow. But even with that, this patient actually underwent resection of some of that left ventricular outflow tract muscle. And this is the postoperative, post-arterial switch procedure, and you can see how this is wide open. There was actually no gradient. So a lot of the patients that initially seem that that the left ventricular outflow tract is not going to allow you to do an arterial switch can actually get an arterial switch with some degree of resection. Now, if the obstruction is significant, then you have to resource to different procedures. So the Rastelli procedure, which is also used for many other diseases, can be used for this condition. So here you have your VSD, you have the pulmonary valve that's small, and you have the aortic valve that's obviously remote coming out of the right ventricle. So what the Rastelli procedure does is you create a tunnel inside of the heart to connect the left ventricle through that VSD and direct it into the aorta. Now the problem with this is that you're actually creating sometimes a very long baffle, and that can create left ventricular outflow tract obstruction in the future. And then obviously you have to give some continuity between the right ventricle and the pulmonary arteries, in this case as a conduit. The Rev procedure is a little bit of a different procedure, although similar to the Rastelli. And what you do is, here you're actually seeing through a ventriculotomy. And the key portion of the Rev procedure is actually a resection of this portion here. So whereas on the Rastelli operation, you're just creating the baffle from the VSD all the way around the conus into the aorta, here on the Rev, you do an intracardiac excision of the conus to make a little bit of a straighter shot between the left ventricle and the aorta. And then you reconstruct the outflow tract, which on the original description of the rev was actually just connecting the pulmonary arteries directly into the RV, but you can also use a conduit. Some people think that this is what makes a rev, but in reality, the rev portion, the intracardiac portion of the rev is the most important step of this. And then the most complicated of the three approaches, but probably what makes most anatomical sense, is the Nikaido procedure. So here you're actually seeing this is where the aortic valve was. This is the pulmonary valve, which is very small, and you have a very large VSD. So since the vessels are transposed, now the aortic valve is sitting on top of a conus of that infundibulous muscle where the pulmonary valve normally sits. So that actually allows you to core out the aortic valve just as you were coring out a pulmonary valve in the case of a Ross procedure. So you core out the aortic valve, then you divide the septum that's dividing the aortic valve and the pulmonary valve, so you're making a huge connection here. And then you move this aortic valve posteriorly to where the pulmonary valve was, and then close the VSD. So the nice thing about this is that you're now creating a direct shot between the left ventricle and the aortic valve. The caveat of this operation, and what makes it very hard, is that you're also moving with the aortic root the coronary arteries. So the incidence on some of the actually larger series of some degree of coronary issues can be as high as 10 to 15%. And then you reconstruct the outflow tract for the pulmonary artery, either with a direct connection and a patch or a conduit or however you want to do the reconnection. And then another special consideration that I wanted to talk about briefly is late presentation. So if you have a transposition with an intact ventricular septum, at some point that left ventricle is going to be untrained. So it's actually now pumping blood to the pulmonary circulation. And if you leave it like that for some period of time, it's just not going to, when you actually have to have the left ventricle do the systemic circulation, it's not going to be able to handle it. Now, when does that transition happen? It's unclear, but for the most part, around 2 or 3 months, you can still do a late arterial switch operation as long as you have some backup, like ECMO and BAD, because some of the patients will require some support post-operatively after that. If it goes beyond that, then your options are two. You either retrain the ventricle, and you can do that with either rapid retraining, which is putting a PA band and a shunt most of the times, for a week, couple of weeks, get enough cardiac mass, and then do the switch. Or do a late retraining, which is just put the PA band plus minus a shunt and let the patient grow for a few months and then come back once the cardiac mass is adequate and attempt the arterial switch. The other option is just the old atrial switch that's not used much anymore, but it's still an option with you doing ascending and muster. And you can add a PA band to kind of also start retraining that ventricle, so at some point you could potentially come back and do an arterial switch conversion. The most important complication is going to be coronary insufficiency, just because of the translocation of the coronaries. You can also have arrhythmias, low cardiac output, ventricular dysfunction, AI. Obviously, you're using the pulmonary valve, what used to be the pulmonary valve. So if you have some PI to start with, that could be a problem. And then the perioperative mortality should be low. Now, this graph is a graph of the mortality by center for arterial switch operation on the STS database. Arterial switch operation, arterial switch VSD. So these are the number of cases per center. Each dot is actually a different center. And you can see how the mortality goes from, in some centers, 0 to some centers 50, or obviously centers that actually are not doing many can be as high as 100%. So there's a huge variability in terms of outcomes for arterial switch operation and some of the other complex operations. What are risk factors for death? Well, the coronary pattern, we talked about intramurality. If you have multiple VSDs, that has been shown to be a risk factor. Older age at repair, especially on patients with intact ventricular septum, and just like anything else, coexisting cardiac and non-cardiac anomalies. Long-term survival should be perfect, should be pretty good. So we're talking about 97 to 98%. That being said, there is some degree of reintervention. So we're talking probably somewhere between 10 and 15% medium-term risk of reintervention. Now, why are we reintervening on these kids? Supravalvular PS is going to be a major thing, 5 to 10%. Late onset of atrial ventricular arrhythmias. Something that we're actually starting to see is neo-aortic dilation in the long term, especially. So just to put things into context, this is an operation that's actually not that old. So This is an operation that we started doing 20, 30 years ago. So we're just starting to see what the consequences are of this arrangement in the long term. And the new aortic root, which used to be the pulmonary root, now we're actually seeing that it may get dilated, we may develop some new aortic insufficiency. And we're also starting to see some coronary problems. So the coronaries are actually not normal. We're essentially creating anomalous aortic origin of a coronary artery by just translocating those vessels, sometimes in places where they usually don't come from. So, and they're going to have some of them interarterial segments, et cetera. So how does that play into the long-term role of coronaries? We don't know yet. So switching gears a little bit into double outlet right ventricle, let's start also with a question. So 6-month-old DORV, large subaortic VSD, started on diuretics 2 months of age, and ACE inhibitors were added at 4 months. He has had marginal weight gain and is intermittently tachypnic. Best management strategy is placing a PA band, creating an LV2 aortic intracardiac baffle, a Nikaido, a Rastelli, or a cardiac cath closure of the VSD. Okay. So, so a DORV with a large subaortic VSD, you should be able to commit the VSD to the aorta because it's basically just next to it. So creating a left ventricular to aortic intracardiac baffle would be the answer. A PA band may not be that wrong, especially on a smaller kid, but you have a 6-month-old that should be able to get a full repair at this stage. A Nikaido and a Rastelli, you don't really need them because you don't need a conduit. The pulmonary valve is actually oriented more towards the right ventricle, so you shouldn't be obstructing it with your baffle. And obviously, cath closure of the VSD wouldn't necessarily be able to create that baffle. So this is an image that I found very useful to understand the relationship between a double outlet right ventricle and the whole spectrum of conotruncal abnormalities. So when you have a normal anatomy, you have the aortic valve is attached to the mitral valve and the cytoskeleton of the heart. And then, as we talked about, the pulmonary valve is going to be sitting on that infundibular muscle, separate from all the other valves. Now, at some point, you're going to start having, if you see this whole spectrum of rotation, so if you start rotating the aorta anteriorly, but still attached to the mitral valve, you're going to have tetralogy of Fallot, where you have an overriding aorta on top of the ventricular septum, which is going to be somewhere around here. You'll have some compression of the pulmonary valve, et cetera. At some point, if you continue that clockwise rotation, the aortic valve is going to detach itself from the tricuspid valve and the mitral valve. And now it's going to be sitting on top of an infundibular septum, an infundibular muscle, just like the pulmonary valve. And that's basically double outlet right ventricle. So you'll have the origin of both vessels, mainly from the right ventricle, the septum being here, and then the orientation of each valve is going to depend whether you're more on the tetralogy spectrum or the subaortic spectrum or the subpulmonary spectrum, depending on how much rotation you have of those conotruncal valves. And if you continue that anterior rotation, at some point the pulmonary valve is now going to be attached to the mitral valve and arising from the left ventricle, and that's transposition. So it's essentially a spectrum of disease where you have normal tetralogy, double outlet right ventricle, and transposition. At least that's how I understand it. So when we talk about an anatomical variance of double outlet right ventricle, you'll have, we'll basically use it between the relationship of the VSD to the great vessels. So when you have a subaortic VSD, you have the VSD in close relationship to the aorta, to the aortic valve. When you have a subpulmonary VSD, the VSD is going to be mainly closer to the pulmonary valve. And that's mainly because of the rotation of both vessels rather than the location of the VSD, even though this diagram shows it to be mainly the VSD changing locations. But here you see that the LV is going to be mainly ejecting through the pulmonary valve, so you're going to have transposition physiology. Whereas here, you're going to have just mainly VSD physiology. A doubly committed VSD is going to be very similar to what we talk about doubly committed juxtaarterial VSDs just in general. So you're going to have a VSD that's underneath both aortic valve and pulmonary valve. And then the non-committed VSD is when your VSD is remote to any of the great vessels. Now, when you think about double outlet right ventricle from a surgical standpoint, all we're thinking of is how do we create a connection between the VSD and one of the great vessels. Once we do that, then we can actually switch the vessels if we need to, but the key is how do we create that connection. Now, another classification, which is a classification that's currently used by the STS, is a more clinical classification, which is divided into 4 types: VSD type, tetralogy type, TGA type, and remote VSD. So a VSD type is when you have either a subaortic VSD or a doubly committed VSD without pulmonary stenosis. A TOF type is going to be when you have either of those two, or you add pulmonary stenosis. A transposition type is going to be when you have a subpulmonary VSD, so you'll have transposition physiology. And then the remote VSD is obviously your non-committed VSD. So as I mentioned, the intraventricular repair is just creating that tunnel between the VSD and one of the great vessels. So what is it going to depend on? Well, obviously the relationship between the VSD and the great vessels, the relationship between the great vessels themselves, how much of an infundibulary septum you have, just because it's going to condition your potential for left ventricular outflow tract obstruction, the size of the VSD, do you have to enlarge it or not to create that baffle? Some people talk about the distance between the tricuspid and the pulmonary valves. All that means is that, for example, in this scenario, if you're trying to create a connection between the left ventricle and the aorta, the distance between the pulmonary artery and the tricuspid valve is actually pretty large. But if the pulmonary valve starts getting more anterior, at some point, if you actually try to create a baffle, that baffle is going to be obstructed because you don't have that much room to navigate around the pulmonary valve. The presence of AV valve cords and associated lesions is also going to be important. So when you have a subaortic VSD, I think it's just essentially like a glorified VSD. It's a little harder because the aorta is going to be more anterior on the heart, so it's a little harder to do technically, but essentially you're just using the patch to close the defect and create an intracardiac baffle. If you have a subpulmonary VSD, then what you're going to do is obviously create that intraventricular connection between the VSD and the pulmonary valve, and then do an arterial switch operation. This is obviously a Taussig-Bing anomaly. Now, the management of non-committed VSD is a little bit more complicated. So the two options are you either do a complex intraventricular repair, and that means finding a way of connecting this VSD to one of the great vessels, which may mean enlarging the VSD, creating a very complicated baffle, et cetera, around atrioventricular valve cords, et cetera, or you have single ventricle palliation. And there have been advocates of both strategies, but most of the recent studies show that for some of these patients, probably a single ventricle palliation may be a better alternative than a complex intraventricular repair that you're going to need to be re-intervening after re-intervention after re-intervention, et cetera. So I made this graph just to kind of summarize the classification and the management of DORV. So if you have a subaortic VSD or a doubly committed VSD with no pulmonary stenosis, that's your VSD type. The treatment, an intracardiac baffle, ideally between 6 and 12 months of age or earlier if the patient needs to, or you can put a band prior to repair if the patient's too small. If you have pulmonary stenosis on any of these two, then that's obviously a tetralogy type, and you're going to do a repair of tetralogy, ideally every 4 to 6 months, and you may need to use a BT shunt. At least that's our strategy. If you have subpulmonary VSD or a Taussig-Bing, then the treatment of choice is an arterial switch operation with an intracardiac baffle, and then aortic arch reconstruction if you actually have an aortic arch coarctation. If you have pulmonary stenosis, then you're going to need to use some of those procedures that we talked about when we talk about transposition, a Rastelli, a Nikaido, or a Rev. And if you have a non-committed VSDs, your options are, you probably want to kind of push the can a little bit, and you either do a PA band followed by single ventricle palliation, or a PA band and intracardiac exploration, and see if there's anything that you can do to do a complex intracardiac baffle in these cases. The survival is actually pretty good on DORV, but the Achilles heel of DORV is going to be your reintervention. So you're actually talking about intracardiac baffles. Those are complicated, and even with tetralogy, VSD types, and Taussig-Bing, they all will have relatively high, I mean, we're talking 20% incidence of reintervention in the midterm. So hypoplastic left heart syndrome, small topic. So you all know the anatomy. You can have mitral stenosis, mitral atresia, you'll have small LV, aortic stenosis, aortic atresia, and a coarctation or aortic arch hypoplasia. So basically you're dependent on your flow from the left atrium, crossing into the right atrium through an ASD, mixing with that, and then you have an outflow through the pulmonary artery into the systemic circulation. So what are the goals of the Norwood operation? So first of all, you want to relieve the systemic obstruction. How do you do that? With the aortic arch reconstruction. Second, you want to provide an adequate and balanced source of pulmonary blood flow. How do you do that? With a systemic to PA shunt, so a BT shunt or a sano conduit. You want to allow adequate pulmonary drainage, so you need to make sure that the ASD is wide open, so you can actually have drainage from the left atrium into the right atrium. And then in addition, some of the considerations that you want to keep is you want to maintain optimal PA growth, preserve tricuspid valve function, optimize ventricular function. So the Norwood procedure basically entails an aortic arch reconstruction that you can either do through using a patch or using different techniques depending on the center, an atrial septectomy, and then creating a stable source of pulmonary blood flow, which can be either a BT shunt or a sano. A BT shunt will come out of the nominator subclavian artery. A sano can actually go from the RV either on the left side of the aorta, or this is the Braun modification where it goes into the right side of the aorta. Now, obviously, on your BT shunts are going to be smaller than your sano conduits because the BT shunt is going to get flow through both systole and diastole, whereas your sano conduit is only going to get flow through systole because it's coming out of the right ventricle. So, question: newborn with hypoplastic left heart syndrome with normal RV function and no TR is put forward for a Norwood procedure. Potential advantages of the sano conduit over the modified BT shunt include lower incidence of branch PA stenosis, lower incidence of reinterventions, avoidance of diastolic runoff, improved long-term ventricular function, or improved tricuspid valve function. So avoidance of diastolic runoff, that's correct. So essentially, as we talked about, you're going to have flow on both systole and diastole on the shunt, and that means that your diastolic pressure is going to be low. So that's where obviously the coronaries get fed, and that's the main caveat of BT shunts. Now, the argument against the BT shunts and for the sano conduits has been, well, you're actually doing a ventriculotomy. How is that going to impact on ventricular function on the long term and similar? But that was actually obviously the main purpose of the SVR trial from the Pediatric Heart Network. What the SVR trial showed was that at 1 year, the incidence of death or transplantation was higher on patients with BT shunts than with RV2PA conduits. So RV2PA conduits had a better short-term survival. Now, these are just published on Circulation, and these are the outcomes at 6 years from this study. What they found is that there is no statistically significant difference now between both shunts. That being said, I mean, you can see that the RV2PA conduit does have a little higher survival than the BT shunt in this population. Now, the main thing about sano conduits is the incidence of reintervention. So this is the graph at 6 years of any cath interventions on these patients. And as you can see, the incidence of cath interventions on RV2PA conduits is going to be much higher than on BT shunts. And most of the times it's just because of distortion of the pulmonary arteries. So if you think about it, you have an RV2PA conduit that's inserting into the PAs, and as the kid grows, that actually starts pulling on the PAs, so you're going to have more distortion of the PAs. Now, at this study, they didn't find any difference in terms of ventricular function in the long term. So that's basically the difference between those two. Now, the hybrid procedure, there was a lot of enthusiasm about this procedure a few years ago. And the goals of the hybrid procedures are the same as the normal procedure, the same principles, right? So how do you, the difference is how you achieve those goals. So the systemic outflow tract obstruction is basically alleviated by putting a PDA stent or keeping the patient on prostaglandin to keep the duct open. You have placement of bilateral PA bands. That's the creation of your stable source of pulmonary blood flow. And then balloon atrial septostomy, which is essentially the equivalent of an atrial septectomy to allow unimpeded flow from the left atrium. Now, the role of the hybrid procedure has actually evolved, and I think there's still a role. The question is, how does this fit on the entire strategy? And this is a very interesting study from the Congenital Heart Surgeons Society on all the centers that form part of the CHSS. and they compare the 4-year survival of patients by birth weight. And as you can see, for patients that are bigger than, say, 2 to 2.5 kilos, the RV2PA conjugate had better survival than the other two strategies. That being said, when you get below 2.5 to 2 kilos, then the hybrids probably have a better survival than both other strategies. So this may be a population where a hybrid procedure, if you have a 1.5 or 2 kilo hypoplast, this may be a good population to use a hybrid procedure on based on this data. What are the results? Well, the early mortality is usually about 10 to 15%. On the SVR trial, the 5-year survival is somewhere around 70%. Actually, it's a little lower at 6 years, 60-something%, with a 10-year survival estimated at 65%. So not great, right? I mean, if you actually have a disease that has a 65% or 70% 5-year survival, that's not a great disease to have. So there's still a lot of stuff that we have to do to improve the survival in these patients. Some of the risk factors, so if you have a restrictive atrial septum or an intact atrial septum diagnosed prenatally, the likelihood of survival, even with fetal interventions and all that stuff, is still pretty poor. You're talking probably 30 to 40%. Low patient weight, associated non-cardiac abnormalities or chromosomal defects, a major one, especially on hypoplast. Tricuspid regurgitation and right ventricular dysfunction are going to be your two main cardiac categories of risk factors. And then some series has shown that diminutive ascending aorta was a risk factor. That has not proven to be the case in most other series. So keeping with the single ventricle stuff, tricuspid atresia. So another question. So a newborn boy is found to have tricuspid atresia type 2C, with small VSD and moderate aortic arch hypoplasia. Which of the following strategies would be an optimal treatment strategy for this child? Aortic arch reconstruction with PA band, a Norwood, a hybrid, aortic coarctation repair through a left thoracotomy followed by a Glenn, or diuretics followed by a Glenn. Okay. Well, if your boards are similar to our congenital heart surgery boards, they love tricuspid atresia transposition. So a type 2C is going to be transposed grade vessels, and they're actually telling you that you have a small VSD. So the worry here is obviously going to be outflow tract obstruction in the long term. And they're also telling you that you have aortic arch hypoplasia, which is another subtle, well, not so subtle sign of possibly having obstruction to the outflow, to the systemic outflow. So aortic arch reconstruction and placement of PA band, in some patients, may be a reasonable strategy. If you really have a small VSD and moderate aortic arch hypoplasia, the concern is that by putting a PA band, you're going to create more hypertrophy, and you're going to actually just create a doubly obstructed heart. So that may not be the best strategy. A Norwood procedure would be the treatment of choice. A hybrid procedure may not be unreasonable. That being said, there's no risk factors on these patients that would actually prompt you to do that instead of a Norwood. The other aortic coarctation repair through a left thoracotomy followed by a Glenn is going to have the same issue in terms of obstruction, et cetera. So that would not be an adequate strategy, and same thing for the last one. So when you're talking about tricuspid atresia, 1 is normally related, 2 is detransposed grade vessels, 3, which is very uncommon, is L-transposed grade vessels. And the way to think about it is A, B, and C. A is atresia, so pulmonary atresia. B is balanced, so you basically have some degree of pulmonary stenosis, but you still have balanced flow. And C is overcirculated, so it's going to be a patient that has an unrestricted VSD if you're talking about a normally related grade vessels. So if you have tricuspid atresia type 1, so normally related grade vessels, your treatment is going to be to provide some source of pulmonary blood flow. So if you have A, so pulmonary atresia, you're going to create a BT shunt or a PDA stent. B, if you have balanced circulations, that may be someone that you want to have close observation until your Glenn. Or C, if you have an overcirculated patient, you want to protect the circulation before the Glenn, so you would be doing a PA banding. Now, when you're talking about tricuspid atresia type 2, the big question is the VSD obstructed or likely to get obstructed? If the answer is yes, then you're going to need to do something different than just putting a PA band or something, and that would be something like a Norwood. So one of the questions is which outflow is obstructed? So normally in congenital heart disease, it's very rare that you have 2 outflows that are obstructed congenitally. So that's the first question you have to ask yourself. Well, if you have pulmonary obstruction, most likely your aortic valve's fine, and vice versa. Now, there's exceptions to the rule, but for the most part, that holds true. If you have an aortic arch hypoplasia, that usually means that your VSD is going to be small or is already small. There have been some studies trying to correlate the dimension of the VSD, and it looks like if the VSD is less than 2 centimeters square of area per meter square of BSA, the VSD is probably going to become a problem. And then you have to take into account that if you put a PA band, that's going to potentially restrict your VSD more. So single ventricle palliation, PA bands are used obviously to restrict pulmonary blood flow. I'm not going to go into clear details, but I mean, it's in general, you want to protect your circulation before going into a Glenn. Shunts, there's multiple types of shunts. The classic BT shunt, it used to be you disconnected the subclavian artery and then swinged it down and connected it to the right pulmonary artery. Actually, the very original one was on the left side, but that's a classic BT shunt. A modified BT shunt, which is what's most commonly used nowadays, is essentially a tube, usually Gore-Tex, usually 3.5, somewhere between 3 and 4 millimeters, depending on where you do it, from the side or from the front. If you do it from the side, we usually use a 4 millimeter shunt. It's essentially a shunt that's going to go from the innominate or the subclavian to the right pulmonary artery. The Watterson shunt is rarely used nowadays, but you may see patients, especially adult congenital patients, that had Watterson shunts in the past, and that was a connection between the ascending aorta and the right pulmonary artery, based on the fact that the right pulmonary artery comes underneath the ascending aorta. Now, the reason why this is important is because a lot of the times these shunts were closed by just opening the aorta and putting a little patch on the shunt and keeping the aorta connected to the pulmonary arteries. So a lot of the patients will have significant right pulmonary artery stenosis. So you see an old TED and you don't know exactly what they had and you have right pulmonary artery stenosis, there's a good chance that they actually had a Watterson shunt, and that's important for us, obviously, because the aorta is essentially connected to the pulmonary artery, even though it's patched. And then the Potts shunt is a shunt between the left pulmonary artery and the descending aorta. That's a shunt that's usually created from the left side. It's not used anymore as a palliation, but it's actually, some people are starting to think about it for pulmonary hypertension to use as a pop-off. So when the pulmonary artery pressure is too high, then you have right to left shunting at the descending aorta level, so you can have desaturation of the lower body without too much problems. The Me shunt or the Melbourne shunt is used for patients with PA-VSD MAPCAs that have very hypoplastic PAs, and it's essentially disconnecting the main pulmonary artery and connecting it to the side of the right pulmonary of the ascending aorta to allow for those pulmonary arteries to grow before coming back and doing a next stage of unifocalization, Rastelli, or whatever you need to do. And then there's some other shunts, like other central shunts that you can create. The Glenn is as you guys know, the second stage. That's just connecting the superior vena cava to the pulmonary artery. And the variation of the Glenn is what's called the hemifontaine. This is a little bit more difficult to understand conceptually, but what you do is you make an opening in the SVC and the right atrium, connect the right pulmonary artery to the atrium, and then you close the connection between the atrium and the pulmonary artery. Now, the reason why you do this is in centers that use lateral tunnel fontaines, it's easier to convert from a hemifontaine to a lateral tunnel fontaine in the future. We particularly don't use it, but some centers do. The fontaine, which is the third stage, obviously, the most common type of procedure now performed is the extracardiac fontaine, which is a piece of Gore-Tex, usually somewhere between 18 and 20 millimeter Gore-Tex graft between the IVC and the pulmonary artery. And the lateral tunnel fontaine is just the creation of essentially put a patch inside of the atrium. You have to open the atrium, and you create a patch to direct the flow from the IVC to the SVC to the pulmonary artery, and that's where the lateral, what the hemifontaine is actually useful. Advantages of the lateral tunnel fontaine is that you can use a fenestration a little easier because you just make a hole in that Gore-Tex patch that you're creating, and you can use it on smaller kids because you don't have to fit an 18 or 16 millimeter conduit on a smaller kid. These advantages is that you're actually needing to stop the heart and open the heart to create the lateral tunnel. And you're also relieving a residual rim or a residual portion of atrial tissue that could potentially get dilated and cause arrhythmias, et cetera, similar to what we're seeing on atriopulmonary fontaines. So what are the perioperative outcomes? Where about 10 to 30% of patients will have persistent pleural effusions. Arrhythmias are not that uncommon. And then the preoperative mortality nowadays is relatively low. We're talking about 0 to 5%. What about long-term outcomes? So this is a series from Mayo comparing the long-term outcomes of different types of Fontanes. You can see the extracardiac Fontanes did better than all the other types of Fontanes in this series. And these were some of the risk factors. So surgical error was an important risk factor. And that probably also was one of the reasons why extracardiac Fontanes did so well, because those are usually done later in the course. And obviously, if you have a high Fontane pressure, high LA pressures, meaning high EDP from diastolic dysfunction, et cetera, it's going to be worse for your Fontane in the long term. This is a series from New Zealand, from the Registry of Australia and New Zealand of Fontanes for the long term. And what they found is extracardiac Fontanes and not autonomous Fontanes, for the most part, do very similarly and much better than atriopulmonary Fontanes. And then in terms of failure, this is basically the incidence of failure considered death, transplantation, Fontane takedown, PLE, plastic bronchitis, or bad functional status. And these are the patients with hypoplastic left heart syndrome. So they tend to do worse than other patients, including patients that have an RV dominance that are not hypoplasts. They tend to do better than those. So question. 4-year-old female with tricuspid atresia is undergoing creation of an extracardiac Fontane. So creating a fenestration in the Fontane circuit would be most useful in which of the following scenarios? Moderate to severe MR, moderate left ventricular dysfunction, recurrent aortic coarctation, increased PVR, or variable AV block. Correct, increased PVR. So I think fenestrations are one of the things that are not completely understood by a lot of people. So we'll talk a little bit about that, but before I want to talk a little bit about Fontane physiology. So when you have a normal heart, you have a left ventricle that's going to give you your pressure, and then that blood's going to go through your resistor, systemic vascular resistance, and then come down to your right atrium or CVP. Then you have a right ventricle that's going to pump blood into the PA. It goes through the pulmonary vascular resistance, and then it goes down into the LA. When you have a Fontane circulation, you have a single ventricle that actually pumps all that blood, and then that blood has to go through 3 resistors. So you have your systemic vascular resistance, you have your conduit, so the Fontane conduit that provides some resistance, and then you have your pulmonary vascular resistance. So what does this cause? Well, first of all, you're going to have an increase in venous pressure, right? So your venous pressure in a normal patient is going to be obviously right atrial pressure. Your venous pressure here is going to be your Fontane pressure. Now, in addition to that, your pulmonary pressure is lower. So, and that pulmonary pressure is actually what's going to give you your preload to the ventricle, which is essentially going to be conditioned by your transpulmonary gradient. Now, that means that the preload that the ventricle has to see is actually very narrow, and you can't change the preload that much. Why? Because any increase on preload is going to drive up all your venous pressure, it's going to drive up your afterload, and it's going to increase the afterload to the single ventricle. So that's one of the things that you actually have a significant limitation on Fontane patients, your preload. And obviously, any increase on your end diastolic pressure, so like left ventricular dysfunction, et cetera, is going to raise the entire pressure and actually make it even harder to go through the entire circuit. So what are some of the mechanisms of Fontane failure? And I'm going to go backwards, starting with systemic obstruction. So obviously, if you have systemic obstruction and increased afterload, that's going to increase your pressure on the entire system. Ventricular dysfunction, same thing. So if you have a rhythm problem, same thing. AV valve function is going to increase your pressure on your common atrium, and that's going to drive things backwards. A restrictive ASD is going to impede your flow from the left atrium to the right atrium, building high pressures that are going to be reflected backwards into your pulmonary circulation. Pulmonary vascular resistance, obviously, PA dimensions, and then if you have significant AP collaterals, may increase your PA pressures, and conduit obstruction or thrombosis. Now, when you put a fenestration, all you're doing is you're equilibrating the pressures, or trying to equilibrate the pressures between your common atrium or your right atrium and your conduit. So this is going to help with anything that's back behind that. It's not really going to help that much with things that are in the front. So if you have AV valve dysfunction or ventricular dysfunction or systemic obstruction or rhythm issues, your right atrial pressure is going to be high. So the difference between your right atrial pressure and your conduit pressure is not going to be that significant, so the fenestration is not going to do as much. Now, on the contrary, if you have high pulmonary vascular resistance, then this pressure is going to be much lower than this pressure, and that's when the fenestration is actually going to serve as a pop-off. So that's the reason why pulmonary vascular resistance was the right answer on that question. So let's talk briefly about aortic coarctation, hypoplastic aortic arch. So another question, 5-day-old girl presents to the emergency room in shock. An echo shows severe juxtaductal aortic coarctation with no PDA. PG is started, and a repeat echo shows a ductus arteriosus that's now open and significant improvement in the coarctation segment. The best next step in management, emergent repair, a cardiac cath with stenting, medical stabilization followed by aortic coarctation repair via left thoracotomy, aortic arch reconstruction via median sternotomy, or a trial of discontinuation of PGE with close observation. Correct. So medical stabilization followed by aortic coarctation. So there's no reason to do an emergent coart repair on this patient that's in cardiogenic shock. Now, if the PGE wouldn't have worked and you don't have a duct and there's still a coarctation and all that stuff within the next few hours, yes, then that would be a reason to do an emergent intervention. Now, the aortic arch reconstruction versus via median sternotomy versus coarctation segment, we'll talk about that. This is a focal juxtaductal aortic coarctation that should be addressable through a thoracotomy. So this is an image of a patient with a juxtaductal coarctation. You see the arch, that's the subclavian, you see the duct there, and you see the narrowing of the juxtaductal segment. So central to that question is going to be the size of the arch. So the proximal arch is going to be that segment between the innominate artery and the left carotid, the distal arch between the left carotid and the left subclavian, and then the isthmus is going to be obviously between the left subclavian and your ligamentum or the PDA. Now, if you're actually thinking about repairing a coart from the side, what you want to know is how the proximal arch is, because you're not going to be able to relieve the obstruction of the proximal arch. So if you actually have a proximal arch that's too small and you do a coarctation, or a coarctation repair through a thoracotomy, you're actually just moving the area of obstruction upwards into the proximal arch. Now, what's a normal proximal arch? That's a matter of debate. So C-scores, so less than -2 C-scores, may be reasonable. The problem is that there's no good C-scores for proximal arch. Some people say 60% of the ascending aorta. Another measurement is the weight in kilograms for newborns or infants +1. So if you have a 3-kilo kid, you should have a 4-millimeter arch. Any of those, they're all imperfect, but those are just considerations that you should keep on the back of your minds. The surgical principles are simple. You want to eliminate the obstruction completely. If you leave residual obstruction, that's going to increase the risk of reintervention and long-term hypertension. And ideally, you want an anatomic repair that uses autologous tissue and that has a very nice convexity to the arch, because that's going to maximize your coupling of the ventricular arterial system and your hemodynamic flow. Indications for intervention, so a significant blood pressure gradient, hypertension, additional cardiac lesions, or elevated end-diastolic pressure. So if you have an isolated coarctation like in this patient, so you have an arch that looks like the proximal arch is adequate based on all the considerations, and then you have a focal area of coarctation, this is a patient that should be addressed via left thoracotomy. And the standard of care is an extended end-to-end anastomosis. So you put a clamp on the proximal aorta, you take all the ductal tissue out, you make an incision distally, an incision proximally, and then you basically slide both the descending aorta and the aortic arch to create a wide open anastomosis. Now, if you have aortic arch hypoplasia, and as I mentioned, if you try to create an extended end-to-end anastomosis, well, that's still going to leave you with significant hypoplasia. And that's in particular, so this is going to be your proximal arch, but this is a patient with a common brachiocephalic trunk, so you really have a very small proximal arch, so you're not going to be able to clamp that proximal arch to move the vessel all the way up. So in those situations, that's when intervention from the front with an aortic arch reconstruction is important. And this done through a median sternotomy. There's different types of procedures. This is just one of them. This is an aortic arch advancement, which basically means ligating the duct, ligating the isthmus, removing all the ductal tissue similar to the other procedure, and then creating an anastomosis to the proximal aortic arch or distal ascending aorta. And this is, for example, a patient after that procedure, and you can see how this is where the arch was before, and you see that convexity, which is exactly what you want to see. Ascending slide aortoplasty, that's another procedure that uses the fact that the aorta on these patients tends to be longer than other patients, so you just use the ascending aorta as a tongue to increase the size of the aorta. You can do a patch. The problem with the patch is that now you're actually incorporating tissue that has different properties from the surrounding tissue, so the risk of aneurysms, et cetera, is probably a little higher. Interposition graft is used on older kids where there's not enough mobility to really bring both ends together, and patients that basically have adult-sized aortas by then. The subclavian flap aortoplasty is actually fallen out of favor for the most part, but that included using the subclavian artery to create to patch essentially the aortic arch and the descending aorta. But the risk of reinterventions are higher, and there's a higher incidence of aneurysms on these patients, besides the fact that you're actually eliminating the subclavian. So the outcome should be pretty good after extended end-to-end anastomosis. Perioperative mortality is between 0 and 5%, and the long-term incidence of recoartation varies from series to series, from somewhere around 3% to about 20% in some series, but should be somewhere around this range. The incidence of hypertension is still pretty high. So most series will report an incidence of 30 to 50%, but that's actually just based on clinic visits. There's a study from Australia where they actually did exercise testing on all these patients in the long term, and what they found is that 90% of patients with repaired aortic coarctations actually had exercise-induced hypertension. So hypertension continues to be a problem. That's something that these patients should be followed for the long term because of risk of intracranial aneurysms, et cetera. Aortic arch reconstruction from the front, the outcome should also be pretty good. Obviously, the morbidity is a little higher than patients that undergo thoracotomies. The perioperative mortality should be somewhere between 0 and 5%, with a long-term recoartation rate also in the low end. And the last topic, for the last few minutes, I just want to talk about vascular rings. And I'm going to start again with a question. So which of the following pathologic entities represent a vascular ring? Left aortic arch with an aberrant right subclavian, a right aortic arch with an aberrant left subclavian, a left PA sling with a complete tracheal ring, a persistent fifth arch, or a right aortic arch with mirror image branching. So correct, a right aortic arch with an aberrant left subclavian artery. A left PA sling is not really a vascular ring, and we'll talk a little bit about that in just a second, but a vascular ring is defined as vascular structures that surround both the trachea and the esophagus. That's the definition of a vascular ring. So when we talk about vascular rings, they obviously, we need to talk a little bit about embryology. So you have 6 arches to start with, and then the body eliminates some of the arches to actually leave. When you have a left aortic arch with normal branching, you have the 4th arch on the left side forming the aortic arch, and then some of the other arches will form some of the brachiocephalic arteries and the PDA. So when you have a right aortic arch with mirror image branching, you have an aorta, ascending aorta. The arch goes onto the right of the trachea and the esophagus, and then you have an innominate artery that creates the carotid and the subclavian. And the duct or the ligamentum basically is an anterior ligamentum that's coming out of here. So there's really, even though you have this right aortic arch, there's no vascular ring because this area here is not surrounded by any vascular structure. On the contrary, if you have a right aortic arch with an aberrant left subclavian, the subclavian, instead of coming out of here of an innominate artery, comes out of the descending aorta through what we call a diverticulum of Komarov, which sometimes can be quite prominent. And the ligamentum will insert at the base of that subclavian artery or diverticulum of Komarov. So if you actually see it on cross-sectional, the ligamentum is actually completing that vascular ring. So that is a vascular ring because you're encircling both the trachea and the esophagus. The second type, main type of vascular ring is going to be your double aortic arch, where you have persistence of both 4th arches on both sides, and you'll have a left arch and a right arch, and usually the right arch is going to be dominant, the left arch is going to be smaller than the right arch, and that's the one that we divide. Indications for surgical intervention, obviously, if the patient has any symptoms, that's an indication for intervention. And some people say that all vascular rings, regardless of symptoms, should undergo intervention because of the low risk. And a lot of these patients, if you actually really talk to them and start exploring things, they'll say, oh, well, yeah, she doesn't like eating solid food that much. She just doesn't enjoy it. Well, some of these patients actually have dysphagia, and after the vascular ring, they actually improve that. So it's kind of interesting. So in terms of how do we treat this, if you have a double aortic arch, we divide the non-dominant arch, which again is generally the left arch. And in this case, we would need to divide both the left ligamentum and the left arch. For a right aortic arch with an aberrant left subclavian, you can divide the left ligamentum only, and that relieves the vascular ring. The problem with that is that some of these patients will still have a prominent diverticulum of Comerle here with the subclavian coming out, and some patients will come back with symptoms. So ideally, for these patients, if possible, the treatment of choice is actually to excise the diverticulum and reimplant that left subclavian into the left carotid artery, which is a more involved operation, but still done through a left thoracotomy. And the series actually show that this is actually a better operation, unless you have huge, I mean, you divide the ligamentum, and there's a huge space, and the carotid is very far away, and it's not going to be an easy translocation from a technical standpoint. Other non-vascular ring arrangements that you'll see is what's called a dysphagia lusoria, and that's just an aberrant right subclavian artery that's with a left arch, and that's coming behind the esophagus. So this used to be thought to be a problem. It is extremely rare that a patient with an aberrant right subclavian has actually symptoms, or that is going to get better with this. So for the most part, these are patients that should not get an operation, unless probably there's a few exceptions, but it's extremely rare. And then innominate artery syndrome is when you have compression of the trachea, of the anterior trachea by the innominate artery, usually because the subclavian artery, because the innominate artery arises a little bit further distal from the arch. And then finally, the left pulmonary artery sling is an origin of the left pulmonary artery from the right pulmonary artery. And what it does is it goes around the trachea and then in between the trachea and the esophagus. And this anomaly is associated with the presence of complete tracheal rings. And the treatment involves basically dividing this and just reimplanting into the left pulmonary artery. And then whether or not to do anything to the tracheal rings depends on whether you have tracheal stenosis or not. If you don't have tracheal stenosis, there's really no reason to address the trachea. But you can see how this is not a vascular ring because it's not encircling both the trachea and the esophagus, and in addition to that, it's not a 360-degree circumferential structure. So that's what I've got. Well, thank you so much.
These are the surgery questions from Dr. Mary, and we start with VSDs. Which of the following scenarios represent an absolute indication for repair of a ventricular septal defect? A, progressive aortic insufficiency associated with aortic valve prolapse. B, presence of a left ventricular to right atrial shunt. C, persistence of the defect after 4 years of age. D, presence of tricuspid insufficiency. Or E, left atrial dilatation. Please choose your answer. Of all these defects, which one has an absolute indication for closure? Easy to miss.
Well, that was a very easy question.
Wow, excellent. You guys are great.
Oh, you guys learned a lot.
Yeah, excellent. ABSD, a recently adopted 5-year-old boy with trisomy 20. We had a few of this in this meeting. Adopted children with a trisomy 21 is found to have a complete ABSD with mild atrioventricular valve regurgitation. He's relatively asymptomatic except for some exercise intolerance. His oxygen saturation is 88% on room air. The next step in management is A, repair of complete atrioventricular septal defect. B, repair of complete atrioventricular septal defect with a fenestrated atrial septal defect. C, placement of a pulmonary artery band. D, cardiac catheterization. E, medical management. On this 5-year-old with trisomy 21 and atrioventricular septal defect with a SAT of 88, what should be the next step? Good. So I was surprised that there will be a question from a surgeon that the answer was cardiac catheterization. I was really happy to see. As you can see, there are a couple of issues sometimes with this question. So this is clearly somebody who is 5 years now is out with low saturations. You're concerned because the risk of pulmonary vascular disease in this patient will be elevated. And you want to know the patient will have a positive or a negative pulmonary vasoreactivity test that Dr. Ivy is going to talk tomorrow a little bit about it when he talks about pulmonary hypertension. But the gist of this question is when a patient presents late for repair, what you want to know is what the PVR is if the patient is operable. Carlos?
Yeah, no, I completely agree. I mean, I think repairing the defect with a fenestrated ASD would be a decision that you would need to make after you get cardiac cath numbers, depending on the numbers that you get. But I mean, yeah, I think doing a cardiac cath would be the next step.
Great. Just because it says TOF doesn't mean that's what the lesion is. A 4-month-old boy undergoes a transatrial transpulmonary repair of tetralogy flow with a small transannular patch. On post-op day 1, he's noted to be hypotensive, 60/40, unmottled, his liver is enlarged, and his core temperature is 101.5 with a peripheral toe temperature of 95. His heart rate is 160, his left atrial pressure is 4 millimeters of mercury, and his central venous pressure is 14. He is on moderate doses of epinephrine. His hematocrit is 38. The best next step in management of this patient would be A, administration of IV fluids, B, decrease in the dose of epinephrine, C, add dopamine, D, initiation of ECMO support, E, cardiac catheterization to assess hemodynamics. Post-op day 1, hypotensive unmottled, high CVP, low left atrial pressure. Sounds like we're not clicking enough votes, I think. Get in there? Oh. All right. Excellent. Well, there might be some controversy on this a little bit, and let me explain. So this is a 4-month-old who does have a high CVP and has a big liver, and we believe that to be secondary to the diastolic dysfunction that you see normally right after tetralogy repair. More inotrophs actually may make for not improvement in diastolic function, actually may make it even worse. You need more time to fill, something that Dr. Mayer mentioned earlier. And we already are on moderate doses of epinephrine. Adding dopamine also wouldn't help because we'll do exactly the same that epinephrine would do. Rarely the answer is initiation of ECMO support in any test. Of course, in real life that might be different. And in this case, given that this is a predictable event in hemodynamic progression of a child after tetralogy of repair, cardiac catheterization probably won't be indicated because you can attribute this to the natural course of postoperative day 1 after tetralogy repair. Carlos?
Yeah, no, that's exactly the point that I was trying to make with this. So you basically have right ventricular dysfunction, you have a high CVP, you have a low left atrial pressure. So your overall fluid status is not necessarily down. So it just means that the patient probably needs a little bit higher preload, probably even lower heart rate. So coming down on the epinephrine may actually help you. You have a high core temperature with a low toe temperature, which means that you're significantly vasoconstricted. And the high liver and high CVP is just right ventricular dysfunction. So
yeah, the core toe temperature discrepancy is like poor man Near's. I guess when I was a resident, and that's what we used. But I think that for many, giving more IV fluids with high CVP may have been a little more difficult to choose. But the diastolic dysfunction after tetralogy is transient. So we expect that the CVP, although it's going to be high, it's going to actually come down as that time goes by. So, a 5-day-old girl is admitted to the ICU after an arterial switch operation for transposition of the great arteries with single coronary artery. Within the first few hours in the ICU, the patient starts exhibiting increasing ventricular ectopy, hypotension, and an increase in left atrial pressure up to 15 millimeters of mercury. A stat echocardiogram reveals new severely depressed left ventricular function, and no pericardial effusion. The next best step in the management is A, cardiac MRI, B, increase in inotropic support, C, afterload reduction, D, administration of diuretics, E, return to the operating room for revision of the coronary button. Please choose your answer. Good. Well, another surprising thing, the surgeon is taking the patient to the operating room.
It's not real life, you know?
Yeah, well, the reason, this question could have different turns, let me explain. So the case illustrates somebody who has ventricular dysfunction for some sort of coronary insufficiency, but this could be the picture of somebody who has mitral regurgitation for some other reason, and on exam you could have heard mitral regurgitation, and that could have given you elevated, LA pressure. But mitral regurgitation after transposition repair is unusual. And also, if you even had mitral regurgitation, you should think that that's probably secondary to ventricular dysfunction. So even if you didn't have an echo and you had mitral regurgitation and high LA pressure, that's something you should be suspicious about. A cardiac MRI will not be as helpful at looking into the specifics of torsion in coronary button anastomosis. Increasing inotrope probably is just temporizing if you want to get the patient to the OR. Afterload reduction definitely wouldn't be the best choice in the early postoperative period when you need inotropy, and diuretics will not also be the right answer as you're having ectopy and hypotension.
Yeah, and the other key in this question is that they're actually telling you that there's a single coronary artery, so you can expect that the operation was probably a little bit more challenging. And in general, the first 5 complications after TGA are going to be coronary related, so you just have to assume that that's the case. And it's actually a vicious cycle. So once you start having some dysfunction, you have left atrial distension, so an increased EDP and all that stuff, and that actually conditions more coronary ischemia, and it's just a vicious cycle that's very hard to get out of.
Great. A 3.5 kilo newborn female undergoes a Norwood procedure with a 3.5 millimeter modified BTT shunt for hypoplastic left heart syndrome with normal RV function and trivial TR. On post-op day 2, she's found to have a blood pressure of 50 over 20 millimeters of mercury, a heart rate of 170, and an oxygen saturation of 70 on 3 liters of high-flow nasal cannula on room air. She is on milrinone at 0.375 micrograms per kilo per minute, and her hematocrit is 30%. The best next step in the management of this patient is A, increase milrinone, B, administration of packed RBCs, C, increase FiO2, D, heparin bolus followed by emergent cardiac cath to assist shunt, E, ECMO support. Please choose your answer. Good. So this is actually a case that illustrates several things. You're having a Norwood operation with a BT shunt or Baylor-Taussig Thomas shunt, however you want to call it, with normal RV function and trivial TR, and has a marginal blood pressure, but and has a fast heart rate with a hematocrit that is 30, without any other signs of low cardiac output. So you are in a reasonable inotropic dose, although there's no mention specifically about perfusion. You assume that when it's not mentioned, that at least that is not affected. So increasing your driving pressure of the BT shunt is what is going to give you a higher saturation. And the way to increase the driving pressure or the pressure head of the shunt here will be by increasing preload. Adjusting for the hematocrit that now is 30 to get it close to 40 will actually make the blood pressure higher, and the pressure head of the shunt will go up and the saturations will go up. If you increase FiO2, that you may actually not achieve this, and still the problem will continue. You may be able to temporize it briefly, but it's not the best next step in the management of this patient.
Yeah, I think if you have a lower saturation with a higher pressure, then yes, your concern would have been about the shunt mainly. But here you basically have a decreased pressure. That's probably what's causing your decreased saturation. So.
And they saved the life yesterday of a patient whose shunt was occluded. They did.
Good.
The 35-year-old male was treated with an atrial fontan early in life, really early. He now represents with exercise intolerance and intermittent shortness of breath. Workup reveals a significant dilated atrium, mildly depressed ventricular function, and atrial flutter with variable conduction on Holter. The best management strategy for this patient is A prosthetic valve insertion in the atrial conduit or the Bjork modification. B, right atrial ablation and medical management of arrhythmia. C, Fontan conversion to extracardiac conduit with MACE procedure and insertion of permanent pacemaker. D, medical management and close observation. E, Fontan takedown to bidirectional Glenn. Please choose your answer. Okay. So the right answer is, in a patient who has an atrial fontan, that Dr. Mary showed the outcomes in actually two different graphs. The significant burden of disease in those fontans is atrial arrhythmias, and the outcomes of patients who have extracardiac fontans long-term are clearly superior. So then the conversion to an extracardiac fontan with a MACE procedure to deal with the IART, the atrial tachycardia, and insertion of pacemaker is actually the right answer. Can you talk a little bit about the choice A?
Yeah, so the choice A is just the prosthetic valve insertion. You would never do that. The Bjork modification was actually just a type of atrial fontan that was done before, and you may still encounter patients that actually have that, but that's not really going to change the problem. So the problem with the atrial fontan is essentially you're connecting the right atrial. They would connect the right atrial appendage to the pulmonary arteries, and that's basically how the flow happened, with or without a valve. But what that does is that the original idea was that you could use the atrial contraction as a driving force to the pulmonary artery. That obviously didn't work in the long term, but what happened is obviously the atrium just gets massively dilated, and that massive dilation makes it a very inefficient circuit, and the massive dilation is actually what gives you all the arrhythmias. So the best management nowadays is to go in, take out part of that atrial wall, do a series of basically a MACE ablation to eliminate the arrhythmia, and then do an extracardiac fontan conversion. So you put an extracardiac conduit.
Yeah, and one of the things that also this shows is that you have a adult congenital patient with exercise intolerance, right, who also has depressed function, probably from the intermittent atrial tachycardia, right, events. So certainly an intervention has to be made. So close observation is not the right answer. The most common long-term complication after repair of coarctation of the aorta via left thoracotomy is A, aortic arch aneurysm. B, recurrent aortic arch obstruction. C, hypertension. D, aortic dissection. E, aortic pseudoaneurysm. Please choose your answer. Good. So in general, the most common, not only long-term, but I will say even an immediate postoperative period hemodynamic problem you got to treat is usually systemic hypertension. Aortic arch aneurysm is associated with the type of repair that either you do a subclavian flap or you do a patch aortoplasty, right? The long-term outcomes of those patients tend to be complicated with aneurysms. Recurrent aortic arch obstruction will be not a common long-term complication on these patients unless there is a residual gradient that was left off during the operation. Aortic dissection is very uncommon, and aortic pseudoaneurysm is also very uncommon when you do repair of native coarctation in the through a direct end-to-end anastomosis. Carlos, can you expand a little bit?
Yeah, the recurrent aortic arch obstruction, I mean, it happens somewhere around 5 to 20%, as we mentioned, and hypertension is actually a very common occurrence if we really look for it. So pretty much almost every patient with after acquired repair is going to have hypertension in the long term. So
I think we're done. Thanks again, and have a good evening.